Good morning, ladies and gentlemen. Good evening to our Asian attendees. Welcome to this new webinar on androgen excess. As you can see in your screen, today our speaker is Professor Irene Lambrinoudaki from Greece, with the topic androgen excess in peri and postmenopausal women. And before Professor Lambrinoudaki to start with her presentation, I would like to remind our attendees that you can leave your questions using the question function that you will find in your control panel. And at the end of this webinar, we will read and our speaker will kindly answer. So please now, Professor Lambrinoudaki, when you want, you can start with your presentation.
So, dear colleagues, I would like to welcome you and especially our colleagues from Asia for attending this webinar, which is a conjoint effort of the European Menopause and Andropause Society and the European Society of Contraception. Today's webinar has the topic androgen excess in peri and postmenopausal women. Our presentation outline, we are going to see how androgen levels change in menopause, the causes of androgen excess in menopause, what are the cardiovascular implications of this state in peri and postmenopausal women, how do we differentially diagnose these women, and finally, how do we manage hyperandrogenism in menopause. Here you see the androgen production in premenopausal women. There are two endocrine glands that contribute to the androgen pool in women, the ovary, which secretes directly testosterone into the circulation, and both ovaries and adrenals secrete androgen precursors. The ovary secretes mainly androstenedione, while the adrenals secrete mainly DHEA and DHEAS. What happens to androgens during menopause? First of all, we have to say that there is a sharp decline in premenopausal years, meaning that a woman of 40 years of age has statistically lower androgen levels compared to a woman of 20 years of age. Menopause per se has no effect on androgen levels. On the other hand, the most crucial factor in a woman during her lifespan of androgen levels is age per se. So we see a gradual decline of androgens in association with increasing age in women. However, menopause is a state of relative androgen excess. And why so? Because we have an abrupt decline of estrogen production in menopause and no change in androgen production. So we have a relative increase of the androgen to estrogen ratio in menopause. On the other hand, in menopause, we have SHBG decline because of aging and mostly because of increase in central adiposity, which is associated with menopause. Testosterone has a high affinity to SHBG, so by lowering SHBG, we have more bioavailable testosterone available. What are the causes of hyperandrogenism in women after menopause? The most prominent cause is a functional one, the polycystic ovary syndrome and states of obesity or states of insulin resistance. These two causes account for most cases of androgen excess in menopause. Of course, we have other more uncommon causes of androgen excess, like congenital adrenal hyperplasia, ovarian hypertrichosis is a state of increase in the stroma of ovary, which is responsive to a laser stimulation, endocrinopathies, like Cushing syndrome or acromegaly, and the intake of medications. We have to take into account the use of antiepileptics because they have other indications beyond epilepsy, and especially the management of chronic pain, which is very often seen in menopause. The tumorous hyperandrogenism is rather rare and consists of adrenal tumors or ovarian tumors producing androgens. Now, as we said before, the PCOS is the most common cause of androgen excess in menopause, whereas in young women, the manifestations are usually infertility, hirsutism, menstrual disorders. As the woman ages and enters the menopause, we see mainly the metabolic disorders of the syndrome, which are obesity, especially central obesity, which is aggravated by menopause, dyslipidemia consisting of low HDL and high triglycerides, hypertension, insulin resistance, defective glucose metabolism, and chronic inflammation. We have fairly good evidence to believe that these hyperandrogenic women with PCOS have deranged vascular function and structure as exhibited by increased intima media thickness, endothelial dysfunction, and increased coronary atherosclerosis. And all available evidence is very nicely summarized here by the recent review of Bart Fauser. And we have also good evidence to believe that women, hyperandrogenic women with PCOS have a fourfold increase in the risk of developing diabetes, and this occurs independently of the presence of obesity. What happens to these women after they enter menopause? In this study performed by the group of Professor Mastorakos, you see a comparison of 20 postmenopausal women with documented PCOS in an endocrine clinic compared to 20 control women postmenopausal matched for age and cardiovascular risk factors. As you see, these women have definitely increased levels of all androgens and at the same time decreased levels of SHBG. And at the same time, postmenopausal women with a history of PCOS have definitely an adverse cardiometabolic profile consisting of central adiposity, increased blood pressure, insulin resistance, high glucose levels, and dyslipidemia. These women also exhibit and accelerated carotid atherosclerosis. And it seems that both insulin resistance and androgen excess contribute independently to increase carotid atherosclerosis, independently of other traditional cardiovascular risk factors. The same is true for arterial stiffness. Postmenopausal women with a history of PCOS and androgen excess exhibit stiffer arteries in postmenopause period compared to control women. Beyond women with a history of PCOS, in the general postmenopausal population, it appears that androgen excess is associated with an adverse cardiometabolic profile. In this group of healthy postmenopausal women, those women who have androgen levels in the highest quartile had evidence of increased serum AGEs. The AGEs stand for advanced glycation end products, substances very toxic to the endothelium. Again, these women in the highest quartile of free androgen index had evidence of arterial stiffness as exhibited by increased pulse wave velocity. Of course, androgen excess contributes to arterial stiffness indirectly through increases in blood pressure or increases in insulin resistance. But beyond the indirect effect, it appears that there is a direct independent association between androgen excess and arterial stiffness in postmenopausal women. This data I showed you were cross-sectional. We wanted to see prospectively the effect of high androgen levels on the evolution of cardiovascular disease. So we performed a study where 180 postmenopausal women had baseline androgen evaluation, and they were followed prospectively for 3 years. The outcomes were blood pressure, new onset hypertension, arterial stiffness, and endothelial function. We observed that at the end of this 3-year period of follow-up, women with in the highest quartile of free testosterone had higher arterial stiffness, a worse endothelial function, and higher peripheral and central blood pressure. But what was most impressive was that these women with a baseline androgen level in the highest quartile had 13% incidence of new onset hypertension, as opposed to only 4% in women with lower baseline free androgen levels. So what have we seen so far? States of premenopausal androgen excess, like PCOS, persist well after menopause. And these states are associated with higher BMI and especially central adiposity and higher insulin resistance. There is evidence of subclinical arterial disease in this stage. However, so far there is no solid evidence regarding cardiovascular events. It might be possible that this effect of androgens is mediated by the adverse metabolic profile which is associated with androgen excess. Now moving to the next part of our presentation, how we differential diagnose this stage. Although the most common cause of hyperandrogenism will be functional, we have to differentiate and locate this very rare cause of tumorous hyperandrogenism because the management in these cases is completely different. Usually, tumorous hyperandrogenism is due to adrenal or ovarian tumors. The best way to differentiate these two states is to take a good and thorough clinical history and perform a good physical examination. Because in the first case, in the functional hyperandrogenism, usually the condition must have begun very early in the woman's life. Usually the onset are in the early reproductive years. We have a mild hyperandrogenemia, which has a very slow progression, and there is no evidence of virilization. On the other hand, in the tumorous hyperandrogenism, we have the onset of symptoms after the menopause. We usually have severe clinical hyperandrogenism, very high levels of androgens, the rapid progression, and we have also virilization present. Here is an illustration to differentiate between hirsutism in the first line, in the first level of the image, and virilization, which is a male pattern hair growth in women's body, along with male pattern alopecia and clitoromegaly. In contrast to adrenal neoplasm, which once they secrete androgens, they are usually malignant, the ovarian tumors which secrete androgens are usually of low malignant potential. However, the only definite diagnosis is the histology. So once found, they have to be excised. Here you see a case we had in our department, in our menopause clinic. This was a 67-year-old lady who presented to us with a very rapidly progressing virilization, which started de novo from the age of 65. We measured testosterone. It was in the male reference range. You see it was 340 nanograms per dl. We performed an adrenal CT and transvaginal ultrasound, which were negative, and then we decided to perform endocrine tests to determine the origin of the androgens. After ACT stimulation test and after dexamethasone suppression test, no change of androgens, so we excluded the adrenal origin of the androgens. However, when we administered LHRH analogs, we saw an abrupt decline of androgen, so we determined that the origin was from the ovary. Finally, by using MRI, we located the 20 millimeter adnexal mass, which was excised. And after 2 years of surgery, her androgen levels were within the menopausal reference range. Now we will move to the last part of our presentation, the management of functional hyperandrogenism. There are two lines of intervention. The first line is lifestyle modification, meaning weight control and physical activity. And the second line is the medical treatment. We have the option of oral contraceptives for perimenopausal women, metformin, anti-androgens, spironolactone or flutamide, 5-alpha reductase inhibitor, which inhibited the conversion of testosterone to dihydrotestosterone, and the most well-studied drug in this category is finasteride, glucocorticoids for congenital adrenal hyperplasia, and finally GnRH analogs usually are given to cases of ovarian hypertrichosis. Concerning the use of oral contraceptives, as you heard in the previous webinars, there are many ways to decrease androgen by using an oral contraceptive. First, you suppress the LH secretion from the pituitary, so you decrease the secretion of androgens from the ovary. You increase the SHBG levels from the liver, so you have increased binding of testosterone, less bioavailable testosterone, and if you use an oral contraceptive with an androgenic progestin, you have a direct blocking effect on the target organ. However, when using oral contraceptives in women in perimenopausal periods with androgen excess, you have to take into account that usually these women have also cardiometabolic risk factors. So you have to be very cautious, especially if the woman is obese, if she's a smoker, or if she is hypertensive. Concerning the effect of physical activity, we have very good evidence, and here is a meta-analysis summarizing all evidence so far, that exercise alone, without the addition of medical intervention, can effectively reduce both total androgen levels and increase sex hormone binding globally, thus reducing bioavailable androgen levels. Especially in postmenopausal women who are glucose intolerant, exercise alone has a better effect in increasing SHBG and decreasing DHEA compared to metformin use. Here you see a trial, 12-month trial, comprising conducted in 235 postmenopausal women with intervention of both hypocaloric diet and exercise. There were 3 supervised exercises and exercise session of 45 minutes and another 2 at home. Among the outcomes was the sex hormone levels. You see that women who were on a diet and exercise at the end of the observation period had a 15% reduction in free testosterone levels. The same was true in another trial, again 12-month period, but here the exercise was lighter. 2 one-hour group sessions and 1 30-minute individual session. But the effect after 1 year was the same again. Reductions in both total and free testosterone levels at a magnitude of 10 to 13%. Now moving to the medical intervention. Metformin is an insulin sensitizer which is very much used in cases of postmenopausal androgen excess. Insulin resistance produces increased insulin production from the pancreas, and increased insulin stimulates both pituitary to secrete LH and target organs, meaning ovaries and adrenal, to produce androgens. If we lower insulin, then we might lower androgen production. Insulin acts both through, metformin acts both through insulin and increases insulin-dependent glucose uptake, but it also can act independently of insulin to activate glucose transporter and increase glucose uptake from cells. The net effect is decreased insulin resistance, decreased insulin production from pancreas, and decreased circulating insulin levels. This is a meta-analysis on the effect of metformin on total testosterone in women. You see the effect is a decreasing one, but it's not so big compared to the use of oral contraceptives. However, when it comes to SHBG, here we have a profound effect of metformin on increasing SHBG levels and indirectly decreasing bioavailable levels of androgens. When we narrow our observation to only postmenopausal women who are insulin resistant and have higher testosterone levels, and if we use the high dose of metformin, meaning 1 gram twice daily, then the effect of metformin is comparable to that of LHRH analogs in terms of decreases of both total and free testosterone and increases in SHBG. Finally, here you see the effect of metformin in more severe cases of functional postmenopausal hyperandrogenism, meaning cases of ovarian hypertrichosis. In 3 out of 4 cases where metformin was administered, we had a 50% reductions in androgen levels. So concluding, androgens decrease gradually with increasing age, and menopause has no net effect on the production of androgens. However, menopause is a state of relative androgen excess. Premenopausal hyperandrogenism, like in cases of PCOS, persists after menopause, and this androgen excess is associated with an adverse cardiometabolic profile. Androgen excess in menopause is usually functional. Newly onset of hyperandrogenism in postmenopausal women merits investigation to rule out a tumorous cause. On the other hand, functional hyperandrogenism will usually respond to lifestyle modifications and possibly metformin. For more severe cases, anti-androgens, 5A reductase inhibitors, or LHRH analogs can be contemplated. I would like to thank you and ask you to book your calendar for the next Congress of European Menopause and Andropause Society, which will take place in Berlin in 2 years' time from now. Thank you very much.
Thank you very much, Professor, for a great presentation. We'll come back to you after a while, after our next activity that we have scheduled for this webinar on androgen excess. That will be our polls. So the way to participate, a dialogue will appear on your screen with a question and 4 possible answers. And you will have a few seconds to answer the option that you think that is correct, and after that we'll tell the results. So here you have the first one. Here are the results from our first poll today. The most common cause of androgen excess in postmenopausal women is 14% of our attendees answered the option A, congenital adrenal hyperplasia. 23% of our attendees answered the option B, ovarian hypertrichosis. 55% of our attendees answered the option C, polycystic ovarian syndrome, and 9% of our attendees answered the option D, steroid-producing tumor. In this case, the correct answer, it was the option C, polycystic ovary syndrome. So we continue with the next poll. Here are the results from our second poll today. The most useful tool in the differential diagnosis of postmenopausal hyperandrogenism is 32% of our attendees answered the option A, clinical history and physical examination. 56% of our attendees answered the option B, serum testosterone levels. 8% of our attendees answered the option C, transvaginal ultrasonography. And 4% of our attendees answered the option D, adrenal imaging. In this case, the correct answer, it was the option A, clinical history and physical examination. And we continue with our last poll today. Here are the results from our last poll today. First line management of functional postmenopausal hyperandrogenism is 17% of our attendees answered the option A, oral contraceptives. 74% of our attendees answered the option B, weight reduction and exercise. 9% of our attendees answered the option C, anti-androgens, and there were no answers for the option D. And in this case, 74% of our attendees were right, and the correct answer, it was the option B, weight reduction and exercise. And now we continue this activity, and in the meantime, while our attendees think that if you have some extra question to our speaker today, Professor Lambrinoudaki, you can use the questions function that you will find in your control panel to write the question, and we will read, and Professor Lambrinoudaki will answer. And I don't know, Professor, in the meantime, if you have some comment regarding the answers from our attendees.
Well, concerning the second question, of course, androgen levels are extremely useful in the differential diagnosis between tumors and non-tumorous hyperandrogenism. But already from the course of history taken and clinical examination, we can make up our mind of what's going on. Because the two clinical presentation, meaning tumors and non-tumors, are completely different. So I think the most important is to examine clinical the patient well, and we will have a working diagnosis already by that. And androgen levels will confirm our clinical diagnosis.
Thank you very much for your comment. It looks like that our attendees don't have extra questions, so I would like to thank you, everyone. Thank you, Professor Lambrinoudaki, for this fantastic presentation. And
thank you for attendance.
Thank you to all the attendees. We know that you are very busy, but before to finish, we have one question that is coming from Andrea Moeller. I will send everyone to the chat for everyone to read. That is, are there any data about the prevalence of hyperandrogenism available?
Sorry, let me read this. Okay. So the various studies have been performed so far are very differently designed. So the prevalence, unfortunately, ranges according to the diagnostic criteria. Of course, if you perform epidemiological studies and you set criteria according to quartiles, as we did it, we cannot estimate prevalence because we, by definition, say that high androgen levels are levels seen in the highest quartile. So this is not a clinical diagnosis. It's very difficult to have clinical estimation of hyperandrogenism in postmenopause. The only definite diagnosis concerning cases of tumors, for example, hyperandrogenism, where diagnosis is easy, permits to conclude that these conditions are extremely rare. So if we want to make a clinical statement, it's not usual. On the other hand, mild hyperandrogenism associated with obesity, and especially central obesity, high BMI and high waist-to-hip ratio, is frequent.
Thank you very much for your answer, Professor. We have one more question. It's coming also from Andrea Moeller. Thank you very much for the helpful and clarifying the answer. Thank you to you, Andrea, for your question.
Thank you.
And looks like that we don't have more questions, so we are very happy to announce that this webinar is being recorded, and you will receive the instructions how to watch again per email. Thanking you for your participation in this webinar. So once again, Professor, thank you very much for being today with us. Thank you for your presentation. And Looks like that we have another last-minute question.
Okay.
So we will transmit again to everyone through the chat. The question is coming from Kyura Lee. Please let me know the basic endocrinology profile to check PCOS such as LH, LH, SHBG, FSH, and testosterone.
So the question is postmenopausally or premenopausally? Usually when we check androgen levels in premenopausal women, we'll ask for FSH, LH to determine the ratio of LH to FSH, SHBG, total testosterone, androstenedione, and DHEAS. This is the usual profile we ask for in women to check for PCOS.
Thank you very much for your answer, Professor. Thank you very much to our attendee for the question. And now I think that we don't have more questions. So once again, thank you everyone, and wishing you to have you in our next webinar in Androgen excess that is scheduled for September with our speaker, Professor Dr. David Carvalho from Portugal, with obesity and androgen excess. So once again, wishing you a very good day and hoping to see you next time. Thank you very much.